Hello, it's me again. I'm back, Gayle Thalmayer. I'm here to talk to you about psychological disorder symptoms in Namibia. As I mentioned in the introduction, psychological science relies disproportionately on Western industrialized samples, a group that we know is not representative of the world's population. And in no domain of psychology is this potentially more consequential and problematic than in that of psychopathology and clinical psychology. As you've been hearing about, we know that cultural context shapes the experiences of psychological disorders and it shapes their appropriate assessment and treatment. But in many countries in the majority world, including Namibia, for example, diagnosis in clinics relies on the Diagnostic and Statistical Manual, the DSM, of the American Psychiatric Association, a source developed and validated entirely in North America. And while universities in Namibia train local clinical psychologists and social workers, their textbooks and training materials are dominated by research from the West. This is not ideal or even adequate, and clinicians and researchers agree there's need for more locally adapted information. Specific to Namibia, we know that there's a lot of trauma given the historical and social context, the fight for independence and the HIV/AIDS crisis. And we know that there's a very high suicide rate, one in the top quartile of the world, and also that there's very minimally available services for psychologists. So the goal of this project is to assess disorder symptoms in Namibia, to validate an efficient instrument to do that, and then to be able to compare symptom frequency to the West. And this is in order to form a basis for future research and also to help inform local psychologists in Namibia so they can continue to better tailor services. In the bigger picture, the goal is to develop hypotheses about how to best adapt assessment to Africa and other majority world contexts, and about how to best think about disorder symptoms cross-culturally in a way that maximizes comparability across contexts in order to make good use of existing knowledge and resources, while also taking local differences into appropriate consideration. And this is one of the goals of the larger 4-year Persona study. It's funded by the Swiss National Science Foundation and run in collaboration between my team in Switzerland and colleagues at the University of Namibia. So I want to talk first about the inventory that we're using in this study. A few years ago, I worked with a team in the United States to create the Cascades Mental Health Assessment. We wanted an efficient screener for disorder symptoms for use in a non-clinical sample. And we found that current inventories tended to focus on a single domain, on psychiatric level problems. They tended to be really long, making them kind of depressing or stressful to complete. They were often proprietary, meaning you would have to pay to use them. And if all that wasn't enough, my biggest pet peeve is these vague response scales. So meaning that you often answer how anxious or depressed you feel or what kind of problems you have with your sleep in terms of whether this happens often, seldom, or rarely. Do you agree a little bit or a lot? This is really subjective, and it leads to reference group effects. To say a little bit more about that, these subjective ratings, you can really only answer these by comparing yourself to people you know well or to what's considered normal in your cultural context, what kind of messages you get about how people should be. And these subjective ratings are one of the reasons, perhaps one of the main reasons, that in survey research we often get counterintuitive findings. and cross-cultural psychologists have established this pretty well. I would argue that it's probably even more problematic for private traits like disorder symptoms. And probably the best solution is to use objective, specific, concrete response options. So the CMHA, which is being tested now, was designed to avoid these different problems. In particular, questions are answered in terms of how many times did you experience this symptom over the last month? And among other things, this allows for a meaningful item level comparison if we don't have good scale properties to be able to make a comparison using scales. We can actually compare at the item level. The CMHA was used in this study along with 2 personality inventories and 3 other inventories, one on religion, 5 items, also the satisfaction with life scale, which Gayle just talked about, and a 1-item measure of physical health. We translated the inventories using a multi-step process that goes well beyond forward and backward translation. I was given the advice to use this better process before starting the study, and I'm really glad I got that advice. It involves using these expert panels where you get together in a room. I was there myself with experts in the domain, both in psychology and in language, and together you come to consensus on what the translation would be. And it leads to a lot of really interesting conversations, and you learn a lot as a researcher. So this is something quite rewarding and that I would highly recommend. In summer 2019, we collected data from 3 samples using 3 different teams, and Gayle just talked a bit about this, so I won't go into more detail about the interviews. The analysis specific to the CMHA, we assess its psychometric properties to see whether it worked consistently across groups in Namibia and to compare it to an American sample in the United States. And we also, as I mentioned, we made comparisons at the item level as a way to look at differences in symptoms across groups. So here is results from confirmatory factor analysis of the 9-factor model in the 3 Namibian groups separately, and then the 3 Namibian samples combined for 1 total Namibian sample. In the paper, we compare some different models. Here, I just want to emphasize that the fit was about the same in Namibia and in the United States, even though this measure was initially developed in the United States, but then adapted to Namibia. The fit was not ideal compared to standard benchmarks for what these values should be. CFI and TLI should be over 0.9, for example. But actually, we would argue that they're quite good compared to domain-specific benchmarks that look at multidimensional inventories. Then looking at measurement invariance. So this is something that, again, Gayle just went over more in her talk, why this is done and what the different levels are. So I'm just going to say very briefly, yeah, this is our way of looking at how consistently the inventory works across groups. And first there in blue is across the 3 Namibian samples. And then we compare Namibia as 1 group, everybody combined, to a sample from the United States, a large sample of over 5,000 cases of employed Americans. And overall, the full inventory, as you can see here, did not meet benchmarks for scalar invariance. It was, on the other hand, pretty good compared to what is seen in the measurement invariance of multidimensional measures in translation. Achieving that scalar level measurement invariance is important in cross-cultural research because it's what allows us to compare means across groups. It's also a bar that is not often reached. And some researchers have even suggested not testing for it. A lot of researchers simply don't test for it. We wanted to test for it so we could see if we can really trust comparing scale scores across groups. But one of our other reasons was just to be able to try to assess where the problems are. What could we do to the inventory to make it work better across groups? And as a start to doing that, what we did was looked at measurement invariance broken down by scale. And we actually found that for 3 of the scales, we had scalar level invariance. So we can compare means there. And that with partner conflict, that meant removing one item, but retaining the other 4. And then for some other scales, we had more problems, especially anger and substance abuse. We had some challenges there. So we're now working with these scales, trying to identify which particular items were problematic, so that we can see if there's things we can drop or parameters we can release that would then allow us to use the scale as a whole. But knowing this would be a complex issue, again, one of the advantages of the CMHA is the ability to compare at the item level. You don't have to address scale issues to make these simple comparisons. How did people in one context on average respond to this item in terms of how often they were experiencing this symptom? So I don't expect you to read this whole list. This is the results by one-way ANOVA with post-hoc tests to assess which items have significantly different average responses across groups. We looked at partial eta square as an effect size, and these are sorted by that. So these are the 20 of the 57 items with the biggest group differences. And interestingly, the differences aren't in a random pattern. It's always the United States where people report the lowest average frequency of experiencing these symptoms. And it's almost always the Khoikhoi speaking group that report them having these symptoms the most often. There's some reasons, some differences between the samples that would make it reasonable that the US might have lower scores. This was a sample where everyone is employed, whereas our people in Namibia, we had a community sample, so we're about half unemployed. But why Khoikhoi speakers should be higher than the other groups in Namibia on these symptoms is another question that we'll need to explore. This figure sorts those biggest differences into which scale they were from, and tries to show by adding the response options on the left there, tries to indicate what this means. You can see that it's the same scales where we had issues with measurement invariance, at least for substance abuse and anger in particular. And having quite different means is one possible reason that we don't have equivalence across groups. So this is also something that's interesting to look at. You can see that for a lot of these symptoms, the US is in yellow there at the bottom, and you can see that the average was close to 0 for most of these symptoms, whereas for the Khoikhoi speakers on average in gray at the top there, for things like these conflicts about substance use and avoidance due to trauma, as well as partner conflict, you can see that actually the average was more than once a month. So people were, a lot of people were reporting having these things happen a lot. We then explored the associations between these psychological disorder constructs assessed by the CMHA scales with the other inventories and with demographic variables. And here I'm just trying to show you briefly that we tracked established associations using a literature review on all these topics between disorder symptoms and the personality traits, religiosity, well-being, physical health, and some demographic variables. And then, so yeah, these show whether it's a negative or positive correlation. In blue is where there's an established across multiple studies a association. And then here's what we observed in Namibia. Of course, just a very brief overview today in this talk. You're welcome to read the paper if you want to get into this in more detail. This is just to show you that orange is for where the hypotheses from prior literature were supported in at least 2 of our 3 Namibian samples. So this is where what we see in this sample in Namibia matches what's typically seen in other places. So these are candidates, these are hypotheses of associations that might be universal. For example, poor physical health correlated with depression. That perhaps that is true everywhere. People that reported higher conscientiousness reported using less substances, alcohol and drugs. That might also be a candidate for something that might be universal. Women also were more likely to report depression than men were. And then in green, we have associations where we hypothesized based on the literature that we would find something, and we didn't. It wasn't supported in 2 or more samples. You can see often it was in 1 sample, but not in 2. So for example, men did not report more substance abuse than women in Namibia. And then in light blue, we have correlations that we observed in the Namibian samples, but that aren't necessarily consistent with prior literature, or maybe they just haven't been studied consistently yet. And again, these are things that would be interesting to explore in future work. So to summarize, the CMHA worked to some extent in Namibia. We're doing some work on it to try to improve scales, to increase our ability to rely on this in the future. We identified areas where some disorder symptoms that seem to have higher prevalence in Namibia, and these we are currently and will continue to explore in detail in some qualitative work, including that was presented by Milena Claudius earlier. So these are things we want to understand. In particular, are people, for example, with substance abuse, people in Namibia reported more symptoms, but some of these symptoms have to do with having conflict with your family about your substance use, or about feeling guilty about your use, and not necessarily about actually drinking or using drugs more. So this is the kind of thing we want to unpack a little bit more. Is this a perception difference, or really a use difference? So I want to thank you all for your attention, and of course, a huge thank you to all the team members who've made this study possible. And I'll look forward to your questions and comments